Hi, everyone. Few more people have joined us, which is wonderful. Hope everyone enjoyed the sunshine today and over the weekend. We're gonna get going. This is recorded, just so everyone knows. And once we get started, we will mute everybody. And then what we'll do is if we have some questions throughout the presentation, feel free to throw them in the chat, and then we can tackle them at the end, just in case any of those answers are gonna come up throughout the discussion. So many of you guys know me. I'm Jamie. I've been on the steering committee since 2012 or 2013. Not sure. I'm longtime IBDer. 2009, I was diagnosed with ulcerative colitis. 2012, got my permanent ostomy. 2018, total prostatectomy. And I am a very pro ostomy advocate on the buddy committee as well here at Sinai. Always happy to chat all things ostomy lifestyle. So if anyone has questions for me or wants to chat about my experiences, always here and happy to do so.
Hi everyone, my name is Ashley. You guys may have seen me in and out either through emails or sometimes coming in person, but I joined the steering committee in 2023. I've been a little MIA since I was in school, but I'm excited to be back and just to, hear all the amazing speakers and just kind of the things that we have lined up. I was diagnosed with Crohn's in 2021 and I had a bowel resection 9 months following my diagnosis. And luckily, I'm hitting 4 years since my surgery and I'm not on any medication. But I have my scope this Friday, so it's looking like, I might have to start some medication. But I think having a support group like this and seeing the amazing people who get to live these full lives, whether you live with an ostomy or you are on medications, I think it's just so uplifting and encouraging knowing that you guys have all been through this journey. And I have so many people to, talk to, get insight from, and, just be a part of this community. So I'm really looking forward to our speaker today. Awesome. Yes. So I'm going to get started with a very quick land acknowledgement. We wish to acknowledge this land on which Mount Sinai Hospital operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to the many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land and continue to build our community here.
Well, thank you. So we're going to get started now. We are very, very lucky to have Luxin Ye, who's a pharmacist here at Mount Sinai Hospital, providing clinical care to GI and general surgery inpatients. She graduated from the University of Toronto Faculty of Pharmacy in 2007 and has been practicing since 2009. Lucin's passion and goals include optimizing medication therapies in IBD patients and providing seamless care to transition patients from hospital to community. So we are very lucky and excited to have here with us. Yay! Okay.
Hello, hello. Thanks for inviting me here tonight. I'm very excited to talk to you guys about something that I'm very passionate about, which is Hmm.
Lexi, you're still on mute, just to let you know, so we can't hear you.
You can unmute yourself. Oh, okay, yeah, I got it. Okay, sorry, I was muted. Okay, hi everyone. Thanks for having me tonight. I wanted to for tonight, I wanted to go through some of the medications options, kind of a very quick overview of what we have in terms of advanced therapies, and then I will also talk about a little bit about biosimilars because that's coming. So, yeah, so thanks for the introduction. I do work here at Mount Sinai Hospital on the inpatient unit. And my patient population is mostly the colorectal surgery patients, general surgery, and also medicine GI, IBD patients. Usually on my day-to-day job is going through medication histories with patients when they first get admitted, reconcile with what they are ordered in the hospital. And then of course, like distribution of medications means getting patients the medications from my pharmacy department to the floor to where the patients are. Yes, of course, making sure that we optimize the use of drugs, make sure they're safe. And the other important thing is for me is to make sure that my patients, you guys have access to the medications, whether funding or whether through insurance or just making sure that the medications that the doctors say that you should be on are accessible to you. And also I answer drug information questions. I talk to patients to teach them or to, talk about medications that they have questions about. So this is today's agenda, very simple. Wanted to go through the 5 different groups of IBD advanced therapy medications, briefly touch on biosimilars, and then open up the time for you guys to ask questions. So when we talk about advanced therapies in IBD, I won't be talking about the steroids or other kind of medications that we also use in conjunction together with the advanced therapies. But when we talk about advanced therapies, we're talking about biologics, right? And then in the past few years, we have seen small molecules like oral pills that in the past we think that, oh, we have to be using injections, it has to be in IV infusions. But in the past few years, we actually started to see oral medications that we can use in advanced moderate to severe IBD diseases. So I wanted to go through the 5 classes. I won't go into too much details, but you guys feel free to ask questions if you want at the end. So when we talk about biologics, biologics are actually antibodies and they are made in the lab. So they're like human made in the lab. They are from living cells. So the source of the biologics could be different. They could be from animals, they could be from bacteria, yeast, etc. So, or there could be a mix of different sources. So they are very large and they're very complicated. I think I do have a picture of, for example, it looks like this. So it's so complex that I can't even describe like how its composition is. So as you can imagine, because it's so complex and it's very delicate, they have to be given as IV infusions because IV infusions or injections because you can imagine our stomach acid would easily just destroy the composition of the drug if we give it by mouth, right? So in the majority of the cases, biologics, we're talking about like infusions, injections, and how they work is that they precisely bind to certain targets in our immune system. And the purpose is to stop inflammation. So other than IBD, other disease conditions also use biologics. So anemia, anything from like diabetes, psoriasis, rheumatoid arthritis, even cancer. I got cancer there twice. Yeah, sorry. So so a lot of conditions nowadays use biologics as a treatment options. Examples. So insulin is actually a biologics. Growth hormones, even the blood thinner, low molecular weight heparin, it is actually also a biologic. Anti-TNFs and Botox, right? So a lot of examples nowadays are actually biologics. So the first class of drugs that I wanted to talk about is the anti-TNF. So I was doing the slides and I was going back to kind of going to write down the dates of when these drugs came on. And wow, the first anti-TNF, which is like the first biologics that we ever used in IBD, Crohn's or ulcerative colitis, infliximab or Remicade. It's been 1998, so it's been 27 years. So, and And then when I said plus biosimilar, it means that the patent of the originator Remicade has expired. So that's why now on the market, there are many biosimilar brands out there making the infliximab molecule. And then after Remicade, we have the Humira, and now we also have the biosimilar of the Humira. And then the Simponi came around the same time as Humira. So the anti-TNF medications are chimeric monoclonal antibodies. Chimeric just means that it's the source of the the antibody is from could be from a mixture of not necessarily human source. So what they do is that they bind specifically to something called TNF alpha. So it's a very small protein. It's called TNF alpha. So what TNF alpha does is that it promotes inflammation in the gut and in other organs in our body. But for the purpose of IBD, by blocking the TNF alpha, we block the inflammation that it's going to cause down the road. So the molecules here, the one on the left is the originator infliximab, and then the one to the right is the biosimilar. And then the second class of medication is called anti-integrin. So the example, and I think that's the only one so far we have, is the Entyvio, which came in 2015. So this one is a humanized monoclonal antibody. Its target is specifically to the alpha-4 beta-7 integrin. So alpha-4 beta-7 binds specifically to MAdCAM1, which is kind of on the gut vascular barrier. So by blocking this, it blocks the lymphocytes from entering the GI tract. So again, that's how it reduces the gut inflammation. And then the third class of medications is called the anti-IL-23 or anti-IL-12. So IL means interleukin. So 4 examples of what we have on the market right now, from Stelara to now they have a biosimilars options, to Skyrizi, to Omvo, and then to the newest one, Tremfya, which just came out this year. So I put them together because the way they work are very similar. So they're mostly targeting the interleukin 23. Some of them target also the 12. But basically, it's also a humanized monoclonal antibody. So they bind to the interleukins 23 or 12, and they are the cytokines responsible for inflammation. So again, the target by binding to the cytokines, it's blocking the inflammation. Yeah, so those are the 3 classes of biologics that we have and we use right now. And then, of course, the biosimilars came along when the originator patents have expired. So other manufacturers, other companies started to make a similar product. So a biologic drug similar to the originator. So Health Canada approves the biosimilars based on clinical trials, based on their safety data. When we call them biosimilar, it's because, like I said, they're very complex protein molecules, and a different manufacturer making it the source of the cells, the process, the cell line, how it becomes the final product. The final product cannot be and will not be exactly the same as the originator complex. So that's why they will never be exactly the same. So that's why we call them biosimilars. But clinically, we expect the biosimilars to work similarly to the originator. And also, we expect the effectiveness and the side effect profiles to be very similar to the originator. And then our Crohn's and colitis website has a very nice explanation on what are biosimilars, if you guys wanted to read a little bit more. So if I were to talk about this a few years ago, I remember, and in 2023, the question was a lot of patients know that by the end of 2023, our provincial government or the funding model was transitioning patients from the originator brand to the biosimilar brand. So the question back then was like, do I really have to switch? And I remember the West Coast, like Alberta, BC, they switched over earlier than us in Ontario. And then eventually by the end of 2023, everybody in Ontario, basically under the Trillium funding or ODB funding, have transitioned to biosimilars when there is a biosimilar available. And of course, the biosimilar drugs also have the same quality of like patient support programs in place. So back then people were really kind of anxious about the switching because they've been doing really well on the originator, and then suddenly the funding changed, and then people had to kind of forced to switch over to a biosimilar. So nowadays, it's been a few years now, from what our experience was about the switching, we didn't really see any big red flags in terms of the switching. So in terms of side effects or safety concerns. So the switching is happening more and more now. And then if we were to ask the question now, it would be which brand or which kind of brand of biosimilar do I start on? Because if we are starting a new patient on a biologic right now, and if there is already a biosimilar brand available, we likely will start with a biosimilar brand. So the question is basically which one? Just because of the funding, it's just so much easier and it's so much faster to get access to a biosimilar brand if it's already on the Ontario funding formulary. So the advantages of biosimilar is funding, and then because the biosimilars are newer, so sometimes their formulation is a little bit better. So they can make it a higher concentration so that in terms of injection, the volume is less, so that patient comfort wise, it's a little bit better. So so these are the advantages of the biosimilars. So now I did mention that we were all used to like the injections and infusions, and then a few years ago, we started to see this thing called JAK inhibitors. And then the first one was back in 2018, the Xeljanz, that we started to use it in UC patients. And then 2 years ago, Ringvoq came on market. So upadacitinib, Ringvoq. And I would say we have used a lot of Ringvoq, and then it is better than Xeljanz. So that's why I really haven't seen Xeljanz being used as much now. So the good thing about the JAK inhibitors is that they are by mouth. Patients can just take the pills once a day at home. No need to go to a clinic, no need to kind of get the injections every week, every 2 weeks. How they work is that they block the JAK enzymes. So the JAKs, what they do is that they activate the signaling messengers to drive inflammation. So tofacitinib or Xeljanz, they block all of the JAK enzymes, whereas the Ringvoq is more selective to blocking the JAK1. So in real world practice, we actually do use a lot of Ringvoq, and the effectiveness for Ringvoq is better. So I think that's probably why we don't really use the Xeljanz anymore. And then a newer class of oral drugs came out, and they're called the S1P modulators. So 2 drugs on the market right now, ozanimod 2022, and then etrasimod 2024. So they are oral, but for now they're only for ulcerative colitis patients. We don't use it for Crohn's, or at least the indication or the approval isn't for Crohn's. So they target the S1P receptors. So the S1Ps are on the surface membranes of the immune cells. So they signal the immune cells to leave from the lymph nodes to travel to the colon. So obviously by binding to the S1P receptors, we're also hoping to reduce inflammation. Practically speaking, I haven't really seen these two drugs used as much. I don't know if it's because I do mostly inpatients. The GIs might be using them more outpatients, but or it could be because they're newer. We haven't really seen a lot of usage yet. Yeah, so those are the kind of the 5 classes of medications that we usually will use for advanced. It's more for like moderate to severe types of IBD conditions, along with, of course, I did mention the steroids, I did mention the 5-ASAs, of course, and they can also have their role here. And then I touched a bit on the biosimilars. It's very kind of a quick glance at things. I didn't go into the details such as like side effects, in like the roles of each one, because it really depends on the patient scenario and the condition in terms of how the GI doctors pick which drug is the best choice. So yeah, happy to open up the time for questions.
There's a question in the chat.
Okay.
I can read it to you. Actually, I can. There might be.
Oh, did you want to read? Oh,
I can do.
oh, actually, do I? Oh, we can see it here.
Access.
Okay, okay. Oh, right, here.
Yeah.
This one
got
from
it.
Sheldon. Okay. The question is, insurers and government are asking those on Stelara to switch to biosimilars, but so far they have not approved Finase, which is just Stelara at a biosimilar price. Why is this an issue? You're talking about, okay, Sheldon, maybe just to clarify your question. Yeah, because Stelara has a biosimilar, at least, maybe not one, maybe at least 2 now, right? Who have not approved? Are you talking about the Ontario drug, ODB?
Yeah.
Are you muted?
Am I muted?
I don't know.
Can you hear me?
Yep.
So I don't understand why Finleas isn't an approved biosimilar, because it's just, you see, if Stelara didn't rebrand themselves as a biosimilar, no one would buy Stelara, which is 40% more expensive than a biosimilar. So all they did was they rebranded the same product and they call it a biosimilar, and it's the same price as all the approved biosimilars. So why isn't it approved? Like what does the company have to do to get it approved? It just, insurers are good at not paying. That's sort of their main business.
Yeah.
So I've been fighting with Manulife for a couple months, and they really don't have an answer. They don't have a lot of resources, let's say, but I just don't understand why they wouldn't approve something. All they want is a cheaper drug, and Finleas is a cheaper drug, like any other biosimilar. So have you encountered any issue like that with other patients? Because a lot of patients would like to stay on the same formulation.
Yep.
And Finleas is exactly the same formulation. It's not like the other biosimilars, which might have slightly different compositions.
I see. So you're saying that the advantage of Phineas is because it's made by the same manufacturer as the brand.
Exactly.
Right? So that's why the preferred biosimilar to switch to is that one, right?
In my case, yes. Why would I want to go to something from a different manufacturer with a slightly, when it's the same price as
I think the problem is that it's not like the status of Phineas is not approved yet. Is that the question? Yeah.
Well, I think Health Canada has approved it, but for whatever reason, the Ontario ODB list hasn't yet put it on the list, which
it takes sometimes because I think the other biosimilars kind of applied earlier, and then hence they got the approval earlier.
And
So it might be.
Manulife is so backwards that they
Mm.
only advised me that I had to switch to a biosimilar recently. You said the biosimilars were approved as of the end of 2023. Well, Manulife was allowing me to take Stelara for the last year and a half.
Mm-hmm. Yeah, so I think Stelara, yes, Stelara, because Stelara's patent expired then, right? So other manufacturers started to make um,
Right.
a biosimilar. And sometimes the insurance company kind of follow. I think a lot of times the insurance company they follow the Ontario provincial funding formulary. So if ODB hasn't really approved or have Phineas on the formulary, um, I think that's why Manulife did not. Yeah, yet. But yeah, but that's something that your coordinator hopefully can kind of continue to make sure that you have access to the brand drug until you can successfully transition, right? I guess your question is
Like,
you don't
yeah,
really
like
get
so
to choose
far,
which biosimilar, right? Yeah.
yeah, like so far they've given me one gratis dose because they're waiting for Manulife to make a decision on the acceptability of Finlius.
Yeah, yeah, yeah. That's yeah, I think with the switching that could be a problem. And then I think yes, you're right in the outpatient setting, like the paperwork and like talking to Manulife for like months is unfortunately quite a common experience with my patients. Yeah.
Yes. Is it easy to contact, I wouldn't know where to start, the Ontario department that looks after the formulary?
Is it easy to contact them? I say you could contact them, but I don't know that they would, I don't know that it would make an impact. Because I think they have a process in place, right? And then a lot of times things just take time.
Mhm.
So I don't think any of us could just call them up to expedite the process. Um,
I'm I'm
Unfortunately.
usually uh, I'm usually good at forcing people to do what they don't want to do.
Yeah, but like I said, we don't expect the switch to be problematic as what we have seen so far with a lot of patients have actually switched with the Remicade and the Humira example. So if patients were doing well on the originator brand, we don't expect a drastic change in terms of the switch. Yeah.
And have you seen patients switch to Weslana?
Sorry, what's the drug? What's
Wezlana.
Oh
It's
yes, that's the
biosimilar for Stelara.
yes, that's the one of the biosimilars. Um, no, like honestly, the usage of Stelara, I don't see it as often now. Because I think the newer drug Skyrizi is out, and then there's a head-to-head trial that the effectiveness is a little bit better with the Skyrizi. So I think yeah, like honestly, I don't see as much Stelara and biosimilar now. I mean, if you're already on it and you're doing well on it, we don't obviously make any changes. But for new starts, I would say, yeah, I don't see as much now because the Skyrizi is out and then the new Tremfya is out. Um, yeah, so I think I'm starting to see more Skyrizi usage. Yeah.
Is it also an injection?
The Skyrizi starts off with IV infusions for at least three doses, and then becomes an on-body injector. So it's an injection after, but the first few loading doses are IV infusions. Yeah.
So I've been on Stelara for a long time and nobody has said anything to me about needing a biosimilar. Is that going to happen?
You must have a
Um,
better insurance company than me.
I think at one point I think you guys all have the program coordinator, right? Like the patient support program coordinator. If they want you to switch, like if your insurance stops funding it, I think your coordinator will contact you and contact your prescriber to do a switch. So I would say if nobody has said anything and then you're still getting your drugs, just keep going.
Okay, I have an appointment with my IBD specialist tomorrow morning, so I really need to know, like, if that's going to be an issue.
But
Yeah,
it really depends on your insurance company or
Yeah.
whoever is funding the bill.
Yep, yep.
It will have nothing to do with your IBD person.
Like the prescriber may not know the specifics of your insurance situation. So I think what they do is they just keep billing it until one day it's or
It
hopefully
stops.
they give you a notice. But yeah, it really depends on the insurance company. But I
And
see potentially in the future they might eventually switch. Because with Remicade, with the experience of Remicade, yeah, I think even the patients who are on originator, like nowadays, like for example, we send patient home with, like we in the hospital start as the brand, originator brand, and then they kind of in the community continue to get the brand until they set up Trillium. And then I think once they have Trillium funding, they will switch over to the biosimilar. The private insurance part is a little trickier, but we just can't guarantee, like I just can't guarantee that it will be forever covered. It's really up to your insurance company. Yeah. But for now, if they didn't say anything, I would just, yeah.
yeah, and what's the biosimilar for Stelara?
It's either Wezlana or Finlius or there's two others, but I think Wezlana is the most
Yeah,
common.
the Westlana. Yeah.
How do you spell that?
Wezlana.
Lana?
Yeah.
Haven't heard of it at all. Okay, that's good to
Yeah.
know.
The biosimilar brands are so many that I don't even know them.
Wow.
But you ask Sheldon for any questions about
Sheldon, thank you.
Stelara, okay?
That's just really worrying. But
I even have the report from Health Canada on the approval of Finlius.
I haven't heard of Finlius at all.
Yeah,
Yeah.
Phineas will have to, like the drug company for Phineas will have to apply to ODB and then wait for it to be unlisted on ODB formulary.
If it's eventually approved, Finlius is exactly Stelara. It's just Stelara by another name.
Mm-hmm.
No name brand.
So it's still by the same manufacturer, it's the same formulation. So that's what I'm trying to do. I'm trying to stick with Finlius, which is an exact copy. It's not really a biosimilar.
Okay, well, that's really good to know. I know that I can contact you if I run into trouble. It's been so good being on Stelara.
Yeah.
Yeah.
Actually, another Stelara question. Another Stelara question. Yeah. Heidi. Okay, Heidi's question. Have you seen patients being transferred from Stelara to the new JAK inhibitor? Usually when they switch, it's because either the drug stopped working, they're in for a flare, or when they get assessed, their disease is not well on Stelara. So I think that prompts the switch. I don't think your GI doctors would easily just switch you from something that you're doing well on to another agent. Yeah, but I can see how someone who's on Stelara could switch to a JAK inhibitor. And have most Stelara patients been transferred to biosimilar in Sinai? We're still on Stelara. Okay. I actually don't know what's happening with the Sinai patients because I look after the inpatient population. So unfortunately, I do only see the sickest people. So when the patients get admitted, I see them. But when you are well and doing okay in the community, I don't really get to see you. Have they been transferred to biosimilar? Yeah, so like we just talked about with Sheldon, right, and Barbara, right? Like it really depends on your insurance company. And if you're really worried, you can talk to your coordinator. You can talk to your Stelara coordinator in terms of what the outlook is in terms of, yeah, potential need to switch. Stelara is Janssen, right? advanced. Yeah, the coordinators should be able to tell you kind of, yeah, roughly where they're looking at in terms of the switch. Yeah.
Barb, which company are you insured with?
Green Shield.
So what you can do, if you're meeting with your IBD doctor tomorrow, is you can tell them as soon as they
Oh, okay.
ask you to switch, you should do one of those drug authorization requests, which can be completed by both the doctor. The doctor just needs to sign it. It really will be filled out by your coordinator.
Yeah, my coordinator has been great. I mean, the whole process has worked really well so far.
Yeah. Yeah. So you get the coordinator to fill out like a but I wouldn't do it ahead of time. I would wait until
I need to.
until your insurer says you got to switch.
Yeah, Green Shield has more trouble paying for this than yeah. I mean, my coordinator actually has been really good at making this happen.
Yeah.
Yeah.
But it is scary.
Yeah. Heidi's question, what is the normal frequency for Stelara dosing? Every 8 weeks, but sometimes your doctor would optimize it by changing the frequency it could be every 4 weeks. So
Yeah, I've been on every 4 weeks for quite a long time.
yeah, so every 4 weeks is yeah, also a dosing that we see. Yeah.
Yeah.
Mhm.
We had a comment to that as well from Jack. So we talked about a contact with
About one of my prescriptions. Yeah, which prescription? Because basically there's a lot of if the drug is not on the ODB formulary and there's no limited use criteria code, it has to be like specially approved. The back office. Okay, yeah. Yeah, is your question on how to get them to approve it? Sometimes, I don't know, sometimes your prescriber is able to, I don't know if they're able to kind of call in to kind of expedite the process. But sometimes for certain drugs, it's just hard to get approval. For example, even like budesonide, like Entocort. It's not super expensive, but it's not cheap. Things like that. I think even Dr. Silverberg had trouble getting some patients approved for the Entocort. So yeah, it's hard to say, depends on what the drug is. And yeah, I don't think we also sometimes have to apply for exceptional access, and then we have in the hospital is a little bit better because we can say that, hey, patients in the hospital, it's discharge limiting or it's holding a bed. But for outpatients, I think the priority isn't there, like from their perspective, and it's hard to expedite that. Jack Tar says, are they going to make an oral drug to take for someone on Renflexis? Are you saying whether Renflexis has an oral version of whether they're gonna make Remicade into oral?
Yes, that's what I'm asking because I'm
Okay. Yeah, I don't. So Remicade right now, infliximab right now I think it has a new injection version of it instead of infusion. But I don't think making it oral is that possible because, like I said, it's a very complex protein molecule. So it has to be in some form of IV or injection because a pill, you do have to swallow it and then our stomach acid will basically destroy all those proteins molecules. So I don't think if you want it exactly Renflexis that it's going to happen as an oral form. It will have to be like another class of medications such as the JAK inhibitors or the S1P modulators. I just don't think like physiologically that Renflexis, it's not gonna work. Yeah.
Okay, thank you.
Do you know anything about something that the Crohn's colitis group has reported called glycocage from BC?
No, can you tell me about it?
It's a breakthrough in IBD treatment. And both an immunologist and an IBD specialist have been working on it since 2018. They have an article in Science. It's a drug delivery system that targets the gut and reduces side effects. So it's like a cage, is what I picture, like a sugar cage. And it goes straight to the area of the gut where it's needed. And it doesn't break down until it gets to the area of the gut where it's needed. And then it opens up and it lets the medication out.
Okay. So that delivery system I have not heard of. Is it already available? Or is it in the trials phase?
I don't think it's available yet, but that's what I wondered if you'd heard of it. It's Glyco Cage.
Oh, I see. So that's okay.
GLYCO Cage, CAGE. It's literally a cage.
Okay. Yeah, I can imagine how that delivery method is very ideal, right? It's kind of protected until it gets to the site and then it gets
Yeah,
to. Yes.
yeah,
Yeah. Cool.
it is cool. I really like the sound of it, but I
Yes,
also,
that's a very ideal model of delivery.
yeah,
Right? It bypasses anything and it
yeah.
just gets to the gut
It just gets
somehow.
to the gut where
Yeah.
it's needed.
Yeah.
I asked him.
Okay, Heidi asks, what level of improvement would you expect from Stelara to say the drug is effective for you if structuroplasty or resection is still being considered after 3 years of Stelara use? Can Stelara still be said to be effective? Heidi, are you asking like how do you say that the drug is effective if you've been on it and then you still need it to have a resection? Yeah, I don't know if from the symptom improvement perspective, whether being on the drug has made any difference. Um, I mean, I could say that the drug could still be doing something, even though that eventually we still have to do a resection. Or I see it this way, like the drug and surgery can both work together, right? And let's say after the surgery, so after the resection, because the structuroplasty or resection, it really depends if the area of disease is already strictured and it's like and it's not because of inflammation, it's already hardened. These drugs that we talk about are really good at reducing inflammation. So if the disease is already the area is already narrowed and not because of active inflammation, I think resection might be needed. But after the resection, after surgery, you could still be on the drug, like for example, Stelara, to kind of maintain to keep your disease in the rest of the bowel quiet so that you don't have a new area of disease down the road. Does that make sense?
Yeah, and then it could be fistulizing versus structural disease.
Yeah. So I see sometimes it's not a drug or surgery. Sometimes drug and surgery can work together to so some, like for example, if your disease is not just in the small bowel, if there's fistulas, there's perianal fistulas, the drug sometimes can also look after maintaining the disease elsewhere. Whereas the surgery takes care of that one part of the structural of the narrowing. Yeah, so overall it's hard to say, right? Like whether it's really from your clinical kind of response to the drug, whether it's working or whether it's effective for you. Is there any other question? Oh,
Have you,
Brain fog. I think originally I had been told by my gastroenterologist that it caused heart issues. And then I think that's been narrowed down in terms of how much that affects the ulcerative colitis patients. Is there any new developments on that?
yeah, I think with the heart disease, I think for now we're still pretty careful in terms of starting patient on like Ringvolt. Like we make sure that obviously we don't have high cardiac risk conditions before we start. Yeah, I'm not aware that there's any new like updated data to kind of overcome what we have already known. Yeah. Because Ringvolt, I think it's still a pretty new drug. Um, yeah, that we might need some time to kind of see the real world safety data. So in terms of selecting patients to start on Ringvolt, I think we would probably still exclude, very kind of high risk cardiac patients. Yeah. Yeah.
Question. I guess my question isn't related to biosimilars or what the clinical making of it, but obviously when the switch happened, as Canada's incidence of cardiac arrest continues to grow, we definitely have more patients. There might be more patients that are inpatient or more patients that need infusions and medication.
Okay.
As a pharmacist, how do we combat medication shortages? So for example, if I'm coming to you, I need to get like that prescription isn't available. What is the course of action that a physician will take in the event that there is a shortage? And I'm also trying to consider the political climate, tariffs, and how that have the impact on buying power for those pharmaceuticals, including biosimilars.
Yeah.
Ms. Mills just saying she can't hear you.
Oh, do you wanna?
Sure.
Yeah.
Hi, I guess so. My question was, just understanding how a pharmacist, because you play such a crucial role in the care delivery of how to combat medication shortages. So what is your, I guess, because I'm interested in knowing what your protocol is, where it's like, let's say as a patient, I come to you and say, I'm going to take Rinvoq, for example, and it's just not available. And obviously you don't have the information for why it may not be available at that specific pharmacy. What is the course of action that a pharmacist would take in the event of a medication shortage? Also, given the current political climate, just cost and burden is something that I guess, I think we'd all be curious about. Yeah, so just wanted to know.
Thanks, Ashley. Thanks for bringing that up. Actually, drug shortage is a thing. Like, I'm glad that you notice it because, like in our pharmacy department, every week we send out a long list of drugs that are on back ordered or in under allocation. Like those are like kind of drugs, right? Like that we normally do use. So far with the advanced medications, we haven't really seen the shortage. I think with the availability of biosimilars, it's actually a good thing that there are multiple manufacturers making the same similar drug. But I think what we do in our inpatients for drug shortage is that we try to use alternatives, right? For example, I think hydrocortisone or it's a steroid rectal foam. We used to love the hydrocortisone foam, but the manufacturer stopped making it for whatever reason. So we just have to kind of explore other options. And sometimes new manufacturers come up with another formula or another drug to replace to meet the demands of the market. But sometimes it's just not available. So it's a bit easier when we're dealing with just the oral pills because, for example, blood pressure medications, instead of amlodipine, we could probably use another calcium channel blocker. But whereas when we talk about more advanced medications, it's not so easy to switch around. It's not like, oh, this blood pressure medication is similar to that one, or it's not like switching between the different proton pump inhibitors for acid reflux, right? So far I haven't seen any for the IBD drugs. It's good. It's good. I don't know. Thanks for bringing that up because
imagining the future, the rates of IBD in Canada or even Ontario are burdensome, right?
Yeah.
They're burdensome not only for physicians, but also pharmacists who have inpatient, but also the pharmacists that have outpatient, like people like us who are doing well in the community.
Yeah.
For answering that.
Yeah. And also, I don't know. I think the manufacturers are also trying hard to not let that happen because, I mean, those are very expensive medications. Once they stop making them, they're not going to get the money. I think I think for now they try really hard to, right?
Yeah.
And then having multiple options, multiple biosimilars, is good. Like for example, Remicade has like so many biosimilars that I'm actually not worried about Remicade.
As long as you're not worried, we're not worried either.
Yeah, I think it's the more the cheaper kind of medications that the manufacturers have less incentive to keep making them. Yeah,
Thank you so much.
no worries.
It's all about the bottom line.
Sheldon, have you seen patients switch from Stelara to Skyrizi or Ringvoq with positive results? It's hard for me to say. Like I said, when I look after the inpatients, we have to switch them because they are kind of not responding to the drug that they're already on. Stelara to Skyrizi, because Stelara and Skyrizi, the mechanism of action is really similar, right? They belong to the same class. So I don't see that switch as often, unless the patient really run out of options of other classes. Switching from Stelara to Ringvoq, I can see that could happen. The good thing about Ringvoq is that it's very fast acting. So within days, we could see whether you were doing better or not. And usually when they're in for a flare, we probably have already started them on steroids once we ruled out all the infections. So yes, we do see a lot of switching to Ringvoq actually in the hospital, because we do have the access, and also it's a very quick acting drug.
Okay.
Thank you. Thank you. Thank you so much. That was wonderful. We can take some time if anyone wants to jump on and do some introductions. I'm just trying to think about how we could do this since we have everyone muted. Maybe we could use like the hand up model. If anyone wants to jump on, we can unmute you. If anyone wants to throw their hand up and do a quick introduction, that would be awesome.
Oh, we're gonna get music.